just going to talk a little bit about management of blunt trauma injury to the cervical spine and when you get an MRI after a CAT scan. So EMS comes in and they're bringing over a patient in a stretcher, it's in a C collar, and they told you that they found the patient found down like that. So the patient looking like that, you would think of hyperextension. And when any C collar injury, a patient with a C collar with a cervical spine injury, you use these two algorithms to diagnose whether or not they need imaging in the first place, to determine whether they need imaging in the first place. So these are usually for alert, stable patients who have blunt trauma to the neck. Obviously, it's penetrating. You don't use NEXUS or Canadian. Just for review purposes, NEXUS and Canadian. NEXUS a lot of us use. It's easier to memorize. It's a less difficult algorithm. The sensitivity is high enough. It's about 90.7%. The confidence interval range, 95%. That confidence interval being 83 to 100%. Canadian, obviously more complicated algorithm, but it can go up to 99.4% sensitivity. Specificity is not that great, so all it means is that both of them have high negative predictive values. NEXUS, you all know this. The four bottom things I bolded because they all require a very good neural exam. These patients have to be alert, awake, and competent and reliable to be able to give you a good neurological exam. And those of you who have problems memorizing NEXUS, those are med students, NSAID is a good one. But generally you do these so often that we memorize them without needing a mnemonic. Canadian C-SPI criteria, a fewer number of us use this. It's more thorough. It only counts for people between the ages of 16 to 65. Not to say that under 16 you have to get a CT scan, but anyone who's over 65 with a cervical injury, it excludes them. No dangerous mechanism, fall from 3 feet or 5 stairs, axial load, high speed, over 60 miles per hour, motorized recreational vehicles, bicycle collisions, but importantly, no paresthesia in extremities. Again, a good neurological exam. They have to be able to answer to you whether they have any focal deficits. And that's not all. So just for completeness sake, if all that is good, you still have to ask, are they have low-risk injuries? And if they are any of these things, then you don't need a CAT scan. And you also derange their neck 45 degrees in either direction. So it's pretty complicated. If you need a mnemonic, 65, still alive, sense deprived, image of alive, slow rec, snow neck, sitting down, walking around, C-spine fine, but please range the spine. Again, the mnemonic is as complicated as the Canadian C-spine criteria, but take your pick one of them. Do not choose one or the other just for the sake of the patient. Stick to one and stick to one for the rest of your practice. So the EAST guidelines in 2009 supports this. It kind of mixes a little bit of both NEXUS and Canadian, not on purpose, but again, a lot of the first three is NEXUS. The bottom one in the full range is more Canadian. But they say that any patients who are alert, awake, and reliable can give all those things. You don't need to do imaging. It's level 2 evidence, almost really, really good. The rest are level 3 and level 4. And what do you do in a neuro exam? You look, you feel, you move, and you do neuro. Look, see if there's any asymmetry, something looks terrible. Obviously, any deformities, you CAT scan. Feel, if you feel the deformity, tenderness, significant tenderness, midline, you CAT scan. You move, check the range of motion, the strength, flexion, extension, lateral rotation, all that is fine. And neuro, tone, sensory, numbness, tingling, reflexes we never do, but that's if you're feeling like a rock star. Image, so any of this is positive. You want to do imaging modalities. You have 3 things at your disposal, really just 2, because the first one sucks. 36% sensitivity, we don't really use it. You don't want to do a flexion extension on your patient in the x-ray if they have an unstable injury. I've only done it once when a patient already had a confirmed injury and neurosurgery wanted it to see if they needed to take them to the OR, but I wasn't doing it. They would do it. CT, this is the one we always go to. It's high sensitivity and very good high specificity. And in the studies that they've done, they are really good at detecting all cervical injuries up to 87.5% sensitivity and 100% in unstable ones. So even if you miss something on the CAT scan, they found out that they're not unstable enough to require the OR. But the MRI remains the gold standard. Very high sensitivity, very high specificity, and it's better than CAT scan for everything except for bony injuries. Detailed spinal cord, detailed imaging of the spinal cord, ligaments, soft tissue, epidural hematomas, and whatnot. So This goes on to say there was a study, they did an adult surgical critical care textbook. 5.8% of patients with negative CT scans found they had a traumatic spinal injury in MRI. It's 5.8%. It's pretty high. Another study, Annals of Emergency Medicine, found out up to 21% of negative CAT scans. 21% of patients with negative CAT scans who had persistent midline cervical tenderness would go on. 18% of those needed to remain on the collar for conservative management for a couple weeks. 3% actually needed to go to the OR. East 2009, therefore, concludes if the CT is negative and the patients are neurologically intact and still complains of pain, you have to get an MRI. And then after that, if it's negative, can you move the C-collar? So we talked about that. But how about obtunded patients? Patients who cannot talk to you, who are not alert, they're intoxicated, or they're totally obtunded. Do you have to get an MRI on all these patients after a negative CAT scan? Level 4 evidence in the case series, not that great, says that it recommends that if the obtunded patient has a negative CAT scan and can perform grossly normal motor movements in all 4 extremities, the CT scan is sufficient. But this is level 4 evidence. East 2009, they did 3 studies, really low N numbers, 46, 51, and 52, found that 11%, 22%, and 30% of obtunded patients with negative CAT scan would have a traumatic spinal injury on MRI. And the study with the 52 patients recommends that you should get an MRI on negative CAT scan patients in the obtunded, who are obtunded. East 2009 goes on to say, if you're obtunded, their final recommendations in 2009 was that the risk-benefit ratio of sending a patient on a C-collar with suspected unstable injury, the risk-benefit ratio of putting him to an MRI and the cost it takes and the risks associated depends on the institution. But ultimately, if the MRI is negative, no matter what your exam is, on obtunded patients, level 2 evidence says that you can move the C-collar if both the CT and MRI are negative. Finally, in 2015, they actually said they conditionally recommend removing the C-collar after only a negative, high-quality negative CT scan. Conditionally. There's basically, conditionally, if you read, it's based on low-quality evidence. Acknowledge that. They say it's low-quality evidence. But given the high negative predictive value of a good CT scan and the cost and risks of putting a patient in an MRI, it's good enough. And I don't know if that's enough for you, but for us, what we can take away from this is that C-spine trauma ideally requires a patient with a good mental status who are reliable and who are alert, can give a good, appropriate, adequate neuro exam. In all the cases, it depends on the patient. Consider an MRI if you have high clinical gestalt that they have an unstable injury. And I'll go back to the patient that I personally had. Brought in a patient like this. Apparently he was 51 years old with a mild MR, had almost every psych diagnosis in the book. Cognitive limitations, mood disorder, psychotic disorder, schizophrenia, and an alcoholic. And he was found down with good vitals. And obviously, this is someone that I may not be able to get a good neurological, reliable neuro exam. This is just essentially his ABCs, everything's, the primary survey, everything was fine except for the tenderness to the C-spine. That was, X-ray is fine, pelvic X-ray is fine. I'm just showing all this because his entirety of the thing was fine. Obviously, if we saw a giant brain bleed or a giant fracture or pneumothorax, we would have to consider there may be other things going on that require more detailed imaging. So when it came to the C-spine, essentially it was negative. The radiologist in VRAD read it as no acute cervical spinal fracture, no traumatic subluxation, essentially no acute findings. He got a pan scan, actually, and everything was negative. And then he was asking to take his cervical, he sobered up, and he was telling us he wanted to take his cervical collar up and get up. Now, did we do that? I got persistent C-spine tenderness. He was able to move both his lower extremities, but he could not move his upper extremities on bilateral command. I wouldn't recommend this, but at the time I just wanted to check if he was reliable. So I raised his arm above his head, and it kept hitting in his head. And he's like, "What are you doing that for?" And that was enough for me to grab ortho to come over and was like, "I think this is real." And ortho thought he was BSing and didn't want it. It was a crazy day. They didn't want anything to do with the patient. They wanted to sign off on it. Thought he was negative and thought the C-collar could be taken off. It's one of my good friends. It was the consult. And we decided to get the MRI because of our findings. And eventually what happened, we found a C2, C3 spinal cord contusion consistent with his central cord findings. And it was pretty bad. And we pulled up my friend over, had a look at the imaging, and they took him straight to the OR. And he got the spinal instrumentation from C2 to C7. So don't blow it. If you have a patient that's uptended, unreliable, and even if ortho was right, and had a point, I would have still got the MRI. We would still got an MRI because the patient was complaining of spinal tenderness. No matter how uptended or unreliable it is, that C collar was not going to come off until the MRI, and we caught this. So for you, with a patient in the ER who has a C collar, who is able to give you a good neurological exam, that's great. But if you're not in a position where you're not able to do that, definitely consider the MRI, even if it's high risk, because you might catch something that would prevent, if you caught it, that would prevent the patient from having lifelong paralysis. That's it.